Upstate Medical University in Syracuse, New York invites you to be the informed patient with the podcast that features experts from Central New York's only academic medical center. I'm your host, Amber Smith. Psychiatrists are debating the use of electroconvulsive therapy after the World Health Organization took a controversial position on the treatment. My guests today are two psychiatrists from Upstate who will tell us more about this. Dr. Justin Meyer is an assistant professor of psychiatry and behavioral sciences who performs and does research on electroconvulsive therapy. And Dr. Thomas Schulze is a professor of psychiatry and behavioral sciences who is also president-elect of the World Psychiatric Association. Welcome back to The Informed Patient, both of you.
Great being back.
Thank you for having us.
Before we get into the controversy, let's start with some background. How do you describe electroconvulsive therapy, or ECT?
So ECT, or electroconvulsive therapy, used to be called shock therapy for those that might have heard that term in the past. It is the most effective treatment we have for a variety of psychiatric conditions ranging from depression to catatonia as well as others. And it works through a variety of different means. Just like any other procedure, we use it when we have to. We weigh the risks, benefits, and alternatives.
How long has it been in use? When was it developed?
So it was first developed in the 1930s, came out of Italy, but it's undergone a great deal of change and advancement over the last almost century now. And so what we did in 1938 in no way resembles what we do today.
How does it work?
So it works through a variety of different means. First and foremost, it acts on the same neurotransmitters that most of our antidepressants do. It causes the brain to release these in abundance and really helps with depression. Some words that you might have heard before: serotonin, dopamine, norepinephrine. So those specific chemicals it helps boost. It also works by having the brain have a seizure, which actually has all the cells firing synchronously and changing the way our brain wires. It allows us to have an opportunity to rewire the brain, and in that way it can break up the circuits that are very deeply entrenched and ingrained with depression and catatonia, as I was talking about earlier. And it actually causes brain growth, neurogenesis within a specific area of the brain called the hippocampus. Why that's important is all of the treatments for depression seem to work on that specific pathway.
Interesting. Now, Dr. Schulze, what was the most recent guidance from the World Health Organization about ECT?
I don't know how familiar folks are with the WHO. I mean, actually, recently, I think people are more familiar because the United States pulled out of the WHO, pulled the funding. So the WHO, the World Health Organization, is the medical or the health organization of the United Nations. And they're headquartered in Geneva. And they are, of course, meant to advise governments as to the health of the global population, as to advise them in, like pandemics we had before, and to many aspects of general health. So, and they have various departments, mental health being one of them. And just recently, last year, they came up with a new guidance. Now, and these guidances, although they are not binding in terms of like United Nations member states, they are a guidance. So the WHO sort of hopes that these guidances be implemented in national law. And what happened last year is that they came up with a major guidance on mental health. And I think what the overall mental health community appreciates is that there is an emphasis on the rights of patients, self-determination, autonomy. That is what psychiatry and all mental health experts really strive for. However, there was in the guidance, there was something, or there is a certain, well, there's like a general feeling, a general message that as regards biological treatments, of which ECT is part of. So there are, from our point of view, very unfortunate comments that put ECT into a very bad light. So there are formulations, and this is I'm quoting here now, there are formulations in there that oversight bodies should ensure that major invasive or irreversible interventions, and then it comes, for example, psychosurgery, electroconvulsive therapy are not practiced or are only permitted with free and informed consent. So first of all, it's not only between the lines, there's a lot between the lines, but it's in the lines where an ECT treatment that Dr. Justin Meyer just so elegantly described is linked to things that nobody does anymore, like psychosurgery, and is basically put in the same sentence with like not permitted, not allowed. And this is where the psychiatric community got really alerted. And that's what triggered the paper that the international community wrote.
So let me explain to listeners that after this guidance came out from the World Health Organization, leaders from some international psychiatry groups, the World Psychiatric Association, the American Psychiatric Association, the European Psychiatric Association, and the Global Expert Task Force on ECT, got together and issued a joint statement basically calling on the WHO to integrate robust scientific evidence and lived experience into future guidance. Do you think this is tied back to, well, the stigma that came out from the movie One Flew Over the Cuckoo's Nest, in which Jack Nicholson was a patient in a psychiatric hospital and he underwent ECT without anesthesia as punishment for his rebelliousness? Is this still kind of alive? Is that concept of that's what it is we're talking about still out there?
Yes, sort of, but only partly because I would say the younger generation, the question is what is younger, but many people like definitely in the maybe 20 years olds, 30-year-olds, they may not even know this movie. And this movie described, as you rightfully pointed out, the patient was rebellious and it was used as a form of punishment. And let's be clear, psychiatry has made mistakes and there were mistakes made. And there was, and maybe Justin wants to speak to that, but I think into the 70s or late 60s, there were these abuses and there was sometimes ECT used as a form of punishment. But I would say nowadays, there is, as far as I understand it, I talk to colleagues, I haven't seen it myself, but there are a lot of portrayals of ECT in many Netflix series. So apparently what used to be only One Flew Over the Cuckoo's Nest, that has, there's more now. There's more. And when they talk about psychiatry in movies and Netflix series, then you get this. And they talk about ECT. So apparently that's what still feeds that. And of course, we all know there are movements, there are organizations that are very much anti-psychiatry, and this is being perpetuated then.
This is Upstate's The Informed Patient podcast. I'm your host, Amber Smith. I'm talking with two Upstate psychiatrists, Dr. Justin Meyer and Dr. Thomas Schulze, about electroconvulsive therapy. Dr. Meyer, do you see ECT portrayed inaccurately in the media?
I think it all depends on what comes up in your feed and what you're watching. There are some really wonderful, accurate representations. A few years ago, Mr. Anderson Cooper did a special in 60 Minutes in which he showed what ECT looked like. And, if viewers are curious, I'd really recommend you take a look at that. He was working with Kitty Dukakis and showing exactly what it looks like. But then again, there are bits and pieces, Netflix series, movies that are out there that I've seen too, that I think touch on this cultural zeitgeist that you're referring to. I think the biggest one was the scene, as it's called in the business, from One Flew Over the Cuckoo's Nest. And even in 1975, when that film came out, ECT was not done, shouldn't have been done as punishment for rebelliousness, as you talked about. And it was not done without anesthesia. The last time that it was regularly done without anesthesia was in the 1950s. And so that was even 20 years removed. So we really have moved far away. And even from 1975, the way ECT was done then is different to now. There's constantly innovations within research that allows us to better target and improve the treatment so it has fewer side effects, better results and outcomes for our patients, and really allows us to be much more refined.
Let's talk about how ECT is done in the modern times. How do you evaluate whether a person is even a good candidate?
It starts with getting a really good history, talking to your client, the person that's in front of you, understanding what they're going through and what they've tried so far. ECT is a really great treatment for specific conditions like depression and catatonia. It's not so great at other ones like PTSD or post-traumatic stress disorder. And so it really starts with getting the story from the patient, understanding what they're struggling with. Some things that we can use to determine if ECT is really going to be very effective is the length of depression. ECT is really good at treating what we call an acute depression, one that sort of comes on suddenly and lasts for a few years. It's not as good at treating somebody that's unfortunately been depressed for 10, 20 years. So there's a lot of those individual factors that weigh in to our decision.
Are there any medical conditions that would disqualify someone from ECT?
No, that's a great question. And the answer is there aren't. The reason being, in medicine and psychiatry too, we really take this concept of informed consent and thinking through the risks and benefits of any treatment. And so if somebody is really severely depressed to the point that they're actively suicidal and going to hurt themselves, that risk may outweigh any and all risks that are associated with ECT. The other part of mental calculus that goes into it is that ECT is actually the safest procedure we have under general anesthesia. So despite it appearing invasive or sounding invasive, it really isn't. It's very safe. And so while there are things that we worry about, for example, somebody's ability to breathe, their pulmonary function, their lungs, as well as their heart, their cardiac function, and we evaluate that closely, it's not a reason we can't do ECT.
And informed consent is important. Are there any situations where ECT may be done against someone's wishes? I'm thinking of cases of dementia where they really maybe aren't able to give their consent.
It's extremely rare that we do ECT without the consent of a patient. It could happen, and it's usually not in the case of dementia, believe it or not. Dementia is not one of the treatments that we typically use ECT for, but sometimes when people are really severely depressed and are convinced that they would be better off dead, that might be a situation where we then go to the family as well as seek a court order and decide with an independent judge whether or not it's something that is appropriate that could potentially save their lives. And I will say that I've done, this is pretty rare in my practice that it comes up, but in the situations that it does, it really is life-changing. You'll see the patient say, oh my goodness, I have no recollection that I was feeling that way, and I'm so grateful that I was able to get this treatment and I'm doing much better now.
If I may chime in, because Justin has so beautifully described that it's actually a very safe treatment and we have safeguards. And this is exactly why the global community of psychiatrists and me representing the World Psychiatric Association and other societies were kind of shocked when we saw that guidance, because what you've just heard from Dr. Meyer here is the state of the art. Every psychiatrist in the world would agree with that. Everyone psychiatrist can tell you exactly that. And then you read in the guidance things like, when it comes to ECT, they talk about harmful practices in mental health care. ECT for children is not recommended and should be prohibited through legislation. There are talks of brain damage, brain changes that might be maladaptive, a complete memory erasure. So what we know from research and the millions of ECTs that are done, I think it's more than 1 million or so a year in the world every year. So this was kind of a punch in the gut, what we had to read. And that's where we had to act. That's why these three major organizations joined forces and came up with this statement. So I just wanted to reiterate that, because Dr. Meyer just nicely pointed out the practice of ECT, the modern practice, how safe it is. And this is in stark contrast to what was portrayed in a very unfortunate way in this WHO guidance.
Does it feel like the WHO guidance is based on the 1930s or 40s?
Well, you wonder sometimes. I think, to their credit, the WHO really likes, and it's important, talks about human rights, the rights of patients, and so forth. And it's very important to bring the patient, the person with lived experience, the family members, all to the table and discuss things when you talk about treatments and so forth. So this is what we call like the trialogue. Not only dialogue, but bring the patient, the family of the patient to the table. That's what we also said in the paper, that we wholeheartedly support that part of the WHO guidance. But in that sort of quest to really just focusing on that, they kind of then, may I say, kind of trashed everything that is sort of biological. Now, this is a stark word, this is a strong word, but this is sort of when you read the guidance, it focuses only on these aspects, which are important, but by doing so, it kind of puts everything that is biological, primarily ECT, into that shadowy corner. And that is dangerous.
It makes me wonder, why did they set it apart, right? Every cardiologist is going to talk to their patients about how they're going to do a cardioversion. Why would I not do that? Every clinician should and does, I believe, talk to their patients about the procedure or treatment for that matter. When I'm starting a patient on an antidepressant, I have the same discussion about risks, benefits, and alternatives. And so it does, what Dr. Schulze is saying, it does call into question why were we set apart in that way? And I was very grateful to Dr. Schulze and the whole team that wrote the paper that we're in part discussing, coming out and making this statement, because it did seem kind of strange to me, wondering why, we were set apart, or why the community of providers that are doing this treatment that saves lives, why are we treated a little bit differently?
Thanks for pointing that out. But you just have to look at the composition of the authors there. They have been there for quite a while. Unfortunately, in this group of authors, there's not a single clinically active psychiatrist. They are not psychiatrists, they're mental health experts, psychologists, great colleagues, but they're not from this field. So think about, now we're having Ebola, and WHO talks about Ebola. Well, there's not an orthopedic surgeon or NT surgeon talking about what we should do in Ebola. So from a psychiatrist perspective, it's really kind of strange to see that guidance comes out where people talk about it without consulting with the experts. And you can always criticize things, and in academia, and you should, but actually there were people on this paper who have been basically outspoken critics for like decades.
Upstate's HealthLink on Air has to take a short break, but please stay tuned for more information about electroconvulsive therapy. Welcome back to Upstate's HealthLink on Air. This is your host, Amber Smith, and I'm talking about electroconvulsive therapy with Dr. Justin Meyer and Dr. Thomas Schulze, two psychiatrists from Upstate. Well, let's talk about how you tell patients to prepare for the procedure. Once they've already decided that they want to pursue this and their family's on board, how practically do they prepare for it? Is it an inpatient procedure?
Well, one of the good things about ECT is it could be inpatient or outpatient. The way we deliver ECT is there's sort of two phases of treatment. The first phase is called the acute phase, where we treat the patient 2 to 3 times a week for about 2 to 4 weeks. They'll come downstairs usually first thing in the morning because they can't eat or drink anything the night before. They come to where I do it is in the PACU, which is the area right outside the operating room, so you're not in an operating suite. And we'll get you hooked up to the monitors to make sure we do everything safely and effectively for you. That whole process, you're awake for, it takes about 20 minutes. Then we'll do a final check. We'll have you drift off to sleep using some medications. Anesthesia is there the whole time. They're going to breathe for you during the procedure. And we use a small amount of electricity, nothing like what you might see on the pit where they're doing a cardioversion and they say all clear. In fact, my hands are literally on the pads delivering the electricity. That lasts about 6 seconds. And then they have a seizure that lasts about 30 to 60 seconds. And then they'll start waking up. That whole part where you're asleep lasts 2 to 3 minutes. They wake up and they recover for about 20 minutes. They're out the door if they're going home in an hour or two. And they'll repeat that process 2 or 3 times a week, again, for about 6 to 12 treatments is on average how long it takes for somebody with depression to get better. The continuation phase, if they're successful, they do well, which we are 70% successful at getting people better from ECT. Then we do what we call continuation ECT, and you do that less frequently, and that's aimed at preventing the recurrence of depression. And we do that once a week or every other week or once a month, depending on where they're at in that process.
Where do the pads get placed? Are they on the head?
Yeah, that's right. So there's two primary placements that most ECT practitioners get. It's bitemporal, so on both sides of your head on the temple, or right unilateral, which is the right temple and the top of your head, the vertex of your head. The right unilateral is one of the newer. It was pioneered about 25, 30 years ago now, but the benefit of that one, which is typically what we do, has fewer cognitive side effects associated with it. So the most common side effects from ECT actually are common things: headache, muscle ache, and nausea. We can give medications for that, and the patients do really well. The less common one that people sometimes worry about 20% of the time, people can have their really cognition affected, which consists of their attention as well as their memory. And it's not their long-term memory. You're not going to forget who you are or where you're from, some things that you might see in the movies, but it's really about the time that you're getting the procedure. So if you went out to dinner the night before the treatment, you might not remember who you were with or what you had for dinner. Likewise, when you're recovering, I don't know if anybody's ever had anesthesia, but usually you're a little out of it, waking up, and so you might not remember some of those experiences either. The difference is that because you're getting it multiple times a week, sometimes it can bleed over, and so that can be challenging. They've done many studies now and looked at patients that have gotten ECT and compared those to that didn't. And about 6 weeks after you stop the procedure, there's really no difference between those two groups in terms of how well they're able to recall and remember. And so we know pretty well that those, whatever deficits you do have, they tend to be short-lived.
How soon do you start feeling the effects? Do you feel less depressed after a few sessions? And does it continue getting better?
Yeah, it's the fastest treatment we have for depression. Our antidepressants typically take several months to really kick in and take effect. ECT takes usually a couple of weeks. So remarkably fast, but it isn't one treatment and done. As I alluded to how it worked earlier through having the new pathways laid down, that takes time and work. And so your brain actually takes some time. And so we do usually see a patient in about a week or so, we can start noticing the difference. But in a cruel twist of fate, usually the patient is the last one to notice that they're starting to improve. That usually the patient will start noticing that improvement after a few weeks, say 2 or 3 weeks.
You're listening to Upstate's The Informed Patient podcast. I'm your host, Amber Smith. My guests are two Upstate psychiatrists, Dr. Justin Meyer and Dr. Thomas Schulze, and our subject is electroconvulsive therapy. What are the risks that you go over and talk to patients about?
So it's the common side effects, so the headache, muscle ache, and nausea that affect about 50% of individuals, but that we're very easily able to treat with our colleagues from anesthesia. They're very gracious and help us out with medications for that, and usually it's no longer an issue. The less common but concerning one is going to be the issues with your cognition, where you might have difficulties with your memory and attention. And then the last but really important one is the risk of death, which I alluded to earlier. ECT is the safest procedure we have under anesthesia, but that being said, it is under general anesthesia and we're going to breathe for you. So the risk of death with the procedure is about 2 in 10,000. So it's very safe.
I read the obituary of Dr. Max Fink, who was a psychiatrist at Stony Brook University in New York. It quoted from his unpublished memoir in which he wrote that observing a full grand mal seizure in each patient jarred me. But then over the next few months, he said, I had learned that ECT effectively reduced suicide thoughts, relieved negativism, aggression, depressed and manic moods. Of the hospital populations, the patients treated with electroshock improved the most. What can you tell us about the patients you have treated with ECT? Does it help?
Yeah, first of all, I just wanted to say thank you for mentioning Dr. Max Fink. He is a giant in the field, and I'm really grateful to him, as well as all of the other people, Dr. Kellner, who taught me, that came before me and really advanced the field and did a wonderful job for our patients. I had a very similar experience to what you just had Dr. Fink describe when I was in training, and I saw the patients that I saw get better the most were the patients that were receiving ECT. It is truly a life-saving procedure that we are doing. I've seen patients that go from not talking, not being able to feed themselves, to being able to walk out the door, live and take care of their children again. And so it really is a tremendous life-saving benefit. I can't say that enough.
Yeah, and I think this is mirrored by so many colleagues from around the world. I mean, for the purpose of this statement, we actually reached out to like 50 colleagues from all over the world, especially in the global south, where ECT is kind of one of those methods for the lack of other, maybe more costly treatments in terms of medication. And they would tell you the same story. I think every psychiatrist has memories of or such situations that Dr. Meyer just described. I just remember during my first year residency at the University of Bonn in Germany, we had a young guy who came. He was severely depressed and he had been on various medications. And he came to that university hospital because he wanted ECT, because he knew that we had it. And yet we said to him, well, let's start with medication. Let's start with this. And it didn't work because it hadn't worked for him because of what people say about ECT. There's even reluctance sometimes among colleagues. And then when we finally sort of granted his wish, we saw exactly what Dr. Meyer just described. This change, a complete change. And this is, again, it's not like all the time, like for every treatment. But when you can see something like that, it definitely changes your perspective on that. And that's why it's so important that we discuss this and that in the world we discuss it and we tell governments and policymakers that this is an important mainstay of modern psychiatry. And we need to discuss it with colleagues at the WHO to make sure that this be available for many more generations to come.
Well, soon it'll be 100 years old, this therapy. What do you see for the future of ECT going into the second century?
Yeah, as I alluded to earlier, it's really evolved so much over the last 90 years, and it's going to continue to evolve as long as we are able to continue pushing the boundaries of research. Some of the things that I see on the horizon for ECT specifically is a lot of excitement about AI as well as individualized medicine, the combination of those two, helping us make a better informed decision for the patient and saying, this patient will very likely respond really well to ECT. This patient may have more side effects, et cetera. So I think that's on the immediate horizon within the next decade or so. And then beyond that, there's going to be other treatments that are sort of taken off of from ECT. Magnetic seizure therapy, or MST, is a new form of treatment that's really targeted in its approach. In a lot of ways, it's on the back of ECT where it's coming from. You're targeting an area, stimulating it, and helping the brain rewire, but maybe with fewer side effects. So that's probably 20, 30 years down the line. So there's always more on the horizon.
That's good to know. I want to thank both of you for making time to tell us about this. Thank you.
Well, thanks for having us and thanks for spreading the good news.
Agreed. Thank you so much for having us. It was great to be here.
My guests have been Dr. Justin Meyer, an assistant professor, and Dr. Thomas Schulze, a professor, both in the Department of Psychiatry and Behavioral Sciences at Upstate. The Informed Patient is a podcast covering health, science, and medicine, brought to you by Upstate Medical University in Syracuse, New York, and produced by Jim Howe, with sound engineering by Bill Brokel and graphic design by Dan Cameron. Find our archive of previous episodes at upstate.edu/informed. If you enjoyed this episode, please invite a friend to listen. You can also rate and review the Informed Patient podcast on Apple Podcasts, Spotify, YouTube, or wherever you tune in. This is your host, Amber Smith, thanking you for listening.